Hi, everyone. I'm so thankful to be here and get to talk about the SYNGAP multidisciplinary clinic that we've set up at Children's Hospital of Colorado, as well as talk through outcome measures for SYNGAP beyond epilepsy today. So my talk is going to focus on discussing why outcome measures beyond seizures are needed in SYNGAP1, talk about the patient-family perspective and what caregivers are hoping to have come forth from a disease-modifying trial, and then go through a novel clinical outcome measure assessment that we're trying out in SYNGAP1, and then give a little plug for our multidisciplinary clinic at Colorado. So in DEEs like SYNGAP1, I think to set up the conversation, it's important to talk about whether it's seizures or the gene itself driving outcomes and developmental delay in SYNGAP1. And so these are separate factors. We know that epilepsy can affect development, but also the gene itself is a driver of developmental delay. Many DEEs have a genetic etiology, and it's believed that that genetic change is causing both epilepsy and the developmental challenges. There's several points of evidence for this, which is that in many conditions, such as Dravet and SCN2A, there's documentation that even when you achieve seizure control, you continue to have developmental delays persist. There's also a wide-ranging neurologic and non-neurologic comorbidities that go along with DEEs, including SYNGAP1 beyond epilepsy. And when we're talking about outcome measures and what we're going to measure in a clinical trial to see what we can have improve, it's very important to take in the caregiver and patient perspective because you guys are the ones living with your Syngapians and are the ones who are going to be able to report what you're seeing in a disease-modifying trial. And I think we have a lot of studies to show that caregivers want things beyond seizure control out of a disease-modifying trial. This is an example from CDKL5 of what parents ranked in terms of what they want outcomes to be and what they care about coming out of a disease-modifying trial. And top concerns were developmental delay, which is before epilepsy and seizures, as well as a host of comorbidities, including GI and feeding problems, speech delay, behavioral disturbances, visual impairment, among others. Another example of this is a study in Angelman syndrome where parents were asked to rank their top priorities for a clinical trial. And once again, neurology, developmental delay, cognitive impairment, and seizures ranked among the top concerns, followed by motor skills, speech delay, sleep, and behavior. And I just want to pause and say that specifically in SYNGAP1, I think using seizure frequency as a primary endpoint is going to be problematic. As we know, one of the most common seizure types in SYNGAP1 is absence seizures with eyelid myoclonia, which I think is going to be very difficult to track in a clinical trial in terms of seizure diaries or parent reporting. Another problematic point is that developmental delay often precedes epilepsy in SYNGAP1, and patients achieve seizure remission at various time points or have seizure onset at various time points. And it's going to be difficult to know whether it's the natural history of that disease causing seizure remission or a drug in a disease-modifying trial. And so the challenges with current outcome measures, so for current disease-modifying therapies, trials such as Stoke and SCN1A, seizure frequency has continued to be a primary endpoint, but I think that falls short of capturing what parents want to see out of a disease-modifying trial. We also need to be able to measure small but meaningful changes, and there's a lack of outcome measures specifically validated in DEEs as a whole. And so some takeaways are that while epilepsy is, of course, a major concern and something that we want improved, it's not the only concern. And disease-modifying therapies should be aimed at improving the whole of a disorder. So we need outcome measures that can measure other concerns such as cognition, motor delays, speech delays, sleep, behavior, and visual impairment. So I'm going to shift to talk about an outcome measure that we're piloting at Children's Colorado that was previously designed and validated in CDKL5 called the Parent Clinician Clinical Severity Assessment. So the CDKL5 Clinical Severity Assessment, also known as the CCSA, was a project that came out of Children's Colorado and has now been validated in CDKL5 through a multi-site team. It went through an extensive longitudinal study and validation process through which it had good metrics and had good psychometric data in these following domains. So the clinician CCSA covers vision, communication, and motor. And the caregiver CCSA, which is a parent-reported measure, covers seizure, behavior, alertness, and feeding or autonomic. So I wanted to give an example of a CCSA item and discuss the scoring because it's a little confusing. So the higher your score, the more severe your impairment. So these are items that are an example of gross motor function on the CCSA. And then I wanted to talk through what we've been doing to pilot this at Children's Colorado. So we have been using this scale, which is a clinician scale that we perform in the clinic. Clinicians are able to do it as part of their neurologic exam. And we have been piloting it in the conditions that we see in our multidisciplinary clinic. So this goes for 8P, STX-BP1, Ring 14, SLC6A1, and now SYNGAP. I did have 2 SYNGAP clinics before I went out on maternity leave. So I've seen 6 patients with SYNGAP1 so far in our multidisciplinary clinic. If you hear babies crying, it's my 2 twins in the background. But hoping to see more SYNGAP kids in the future and increase the numbers on this graph. But I think from very small, very early numbers being the caveat, SYNGAP1 appears to mirror SLC6A1 pretty heavily, with scores kind of being in the medium to mild range on the overall clinician CCSA score. And even though we've seen 6 kids in the clinic, 5 have been consented and 2 have had caregiver scales come back. So that's the numbers that you see here. But once again, also look to be kind of in the moderate range on the caregiver scale. And then I wanted to separate the scores out by domains because this is where I think it gets really interesting. So you can see on the clinician scale, I've separated motor, communication, and vision out. And once again, I think scores are looking a lot like SLC in terms of kind of mild to moderate impairment, with communication being the most impaired. And then the caregiver CCSA scores, I don't think this is going to come as any surprise to anyone in this room, but we see a high score for behavior for SYNGAP1 as well as SLC6A1, as well as significant autonomic and alertness impairment. And then I just wanted to give the ranges for the 5 kids that I've had the pleasure of seeing so far and show that by and large, for the clinician CCSA, the most impairment we see is in communication, though there is a wide range. And we have a separate visual domain on the CCSA, which I'll talk about in just a moment, that evaluates for CVI. And I've actually seen a very low level of visual impairment in SYNGAP1 so far. But CVI is something that we like to evaluate and talk about in our clinic. I think it's important to be screening for cortical visual impairment in all of our kids with DEEs, as it can be easily overlooked and not diagnosed. And a diagnosis of CVI can give you really important services in school, as well as therapies at home. So we ask standard visual screening questions, such as does the family have concerns about vision? How is the child looking at things? Are they looking out of the corner of their eye? Or are they actually looking at an object? And how does the patient go downstairs and cross thresholds, as these can be kind of red flags for CVI? We also use the visual components of the CCSA to help us give a diagnosis of CVI. To give a diagnosis of CVI in our clinic, a child needs to have seen an ophthalmologist and proven that the structure components of the eye are intact, so that we're able to give a diagnosis of CVI. But if we see these signs, we will give a diagnosis in our clinic. And these are just some of the visual components on the CCSA. So fixing and following, the optokinetic nystagmus reflex, eye alignment, and nystagmus are some of the things we look for. And then I just wanted to give a plug for our clinic. So like I said, it's a multidisciplinary clinic at Children's Hospital Colorado. We are part of the natural history study, the PROMISE study, along with CHOP. And we would love for people to come see whichever clinic is more convenient for you geographically. Our multidisciplinary clinic includes many providers such as neurology, rehab, PT, OT, speech, genetics, special care pediatricians, developmental peds, and psychiatry possibly in the future, as well as a neuropsychologist who does evaluations the day prior to clinic. And this is all part of our neurogenetics multidisciplinary clinic program at Children's Colorado that sees all of these different conditions. Apologize for the twins. And so this is our clinic flow. The day prior to kind of the full multidisciplinary clinic day, we typically have kids see our neuropsychologist who does a battery of neuropsychological assessments that are going to be important for long-term natural history data, as well as discovering endpoints. And then our multidisciplinary clinic includes all of those providers I just mentioned. And then we also have a special care pediatrician who sees kids in the opposite half day that you're seeing in our multidisciplinary clinic, which is really great as they're able to kind of run a full kind of review of systems and cover all the different organs that we don't cover in our multidisciplinary clinic and determine if any other subspecialists are needed.